Welcome to The Explainer. Today we're hitting a high-yield clinical flashcard board review covering surgical infections and trauma. The pace is going to be relentless. We're covering 12 crucial multiple-choice questions, the definitive answers, and the exact exam pearls you need to memorize. Let's go.
MCQ 41. Which of the following antimicrobial agents is highly effective for treating surgical site infections driven by MRSA? A. Cefepime. B. Vancomycin. C. Metronidazole. D. Nafcillin. Or E. Cloxacillin.
The correct answer is B. Vancomycin. Okay, let's dive into this. MRSA strains possess altered penicillin-binding proteins, specifically PBP2A, encoded by the MEK-A gene. This literally renders them resistant to all standard beta-lactams, including nafcillin and cloxacillin. Effective agents? You're looking at vancomycin, linezolid, daptomycin, and teicoplanin. Remember this warning. Flucloxacillin and cloxacillin are strictly ineffective against MRSA. MCQ 42. Which of the following beta-lactam class antibiotics exhibits reliable bactericidal activity against Pseudomonas aeruginosa? A. Vancomycin. B. Erythromycin. C. Imipenem. D. Amoxicillin. Or E. Methicillin. Choice C, imipenem, is correct. Imipenem with cilastatin and meropenem are ultra-broad-spectrum carbapenems providing absolutely excellent coverage against Pseudomonas aeruginosa. Other reliable anti-pseudomonal options include extended-spectrum penicillins like piperacillin/tazobactam, cephalosporins like ceftazidime and cefepime, fluoroquinolones like ciprofloxacin, and aminoglycosides like gentamicin. MCQ 43. What is the recommended timeline to initiate enteral tube nutrition in a severely burned adult patient? A. Within 6 hours. B. After 24 hours. C. Post-admission day 2. D. Post-admission day 3. Or E. After positive bowel sounds. The correct answer is A, within 6 hours. So the crucial point is this 6-hour threshold. Severe thermal injuries cause a massive hypermetabolic state. In patients with burns involving greater than or equal to 20% of their total body surface area, early enteral feeding limits that hypermetabolism. The big metabolic pearl to remember here is that adults with burns greater than 15% TBSA have significantly increased demands requiring early nutritional support.
MCQ 44. Deep, dirty laceration with unknown tetanus immunization history. What is the standard prophylaxis protocol? A. Tetanus toxoid alone. B. Tetanus immune globulin alone. C. A 3-dose course of tetanus toxoid alone. D. A 3-dose course of tetanus toxoid plus TIG. Or E. Local wound care plus oral antibiotics.
D is the right choice. You absolutely need both active and passive immunization for a tetanus-prone, contaminated wound with an unknown history. And this brilliantly illustrates the exact timeline of the adult active course. It dictates immediate passive immunity from the human tetanus immunoglobulin to neutralize unbound toxin, while the active tetanus toxoid course gives you that long-term protection. Dose 1 is given immediately, dose 2 at 1 to 2 months, and dose 3 at 1 year.
MCQ 45. Appropriate tetanus prophylaxis for a clean household incised wound with an unknown vaccination history. A. Debridement alone. B. Debridement plus TIG. C. 3-dose tetanus toxoid alone. D. Tetanus toxoid plus TIG. Or E. IV penicillin.
The answer here is C, an active immunization course alone. Clean household injuries carry a very low risk for tetanus spores, so passive immunization with TIG is just not indicated. Here are your clean wound protocols. If fully immunized within the past 5 years, no treatment is needed. Greater than 5 years requires 1 dose of tetanus toxoid. For unknown or unvaccinated status, it is the full 3-dose active series with 0 TIG.
MCQ 46. Next step for superficial abrasions with road debris and a documented tetanus booster 4 years ago. A. Tetanus toxoid only. B. Tetanus toxoid plus TIG. C. Nothing needed if within 5 years. D. TIG only. Or E. None of the above.
Option C is correct. Nothing is needed if the booster was given within 5 years. For high-risk tetanus-prone wounds, if the last booster was less than 5 years ago, nothing is required because protective antibody titers remain high. If the booster was 5 to 10 years ago, you give 1 booster dose of tetanus toxoid. If it's been greater than 10 years, give 1 booster dose of tetanus toxoid plus 1 dose of TIG.
MCQ 47. Which of the following biological profiles correctly describes the genus Clostridium? A. Contain endotoxin. B. Secrete exotoxin. C. Gram-negative rods. D. Spore-forming cocci. Or E. Aerobic bacteria.
The correct answer is B. They secrete exotoxin. Clostridium species are obligate anaerobic, spore-forming, gram-positive bacilli that exert their virulence via highly potent exotoxins. Let's rapidly review these high-yield exotoxin profiles. C. tetani secretes tetanospasmin, causing lockjaw. C. botulinum secretes botulinum toxin, causing flaccid paralysis. C. difficile secretes toxins A and B, causing pseudomembranous colitis. And C. perfringent secretes alpha toxin, causing gas gangrene.
MCQ 48. Microbiological profile most commonly isolated from type 1 synergistic necrotizing fasciitis. A. C. welchii. B. Staphylococcus. C. Group A strep. D. B. fragilis. Or E. Polymicrobial flora. E is the correct answer, polymicrobial flora. Now, what's really interesting about this slide is the strict contrast between the classifications. Type I is fundamentally a polymicrobial infection driven by a synergistic mix of gram-positive coccus, gram-negative aerobes, and obligate anaerobes. Conversely, type 2 necrotizing fasciitis is monomicrobial, most frequently driven by group A beta hemolytic streptococcus.
MCQ 49. High fever, crepitus, severe pain out of proportion after a hand injury. Most likely implicated organism? A. Clostridium welchii. B. Staphylococcus aureus. C. Group A strep. D. Clostridium perfringens. Or E. Pseudomonas aeruginosa.
Choice C, Group A beta hemolytic streptococcus is correct. This organism is the most common cause of monomicrobial necrotizing fasciitis. You absolutely must recognize the clinical red flags for necrotizing fasciitis: palpable subcutaneous gas, or crepitus, woody induration, skin bully, and severe pain entirely out of proportion to clinical signs.
MCQ 50. Which statement is true regarding the pathophysiology and management of gas gangrene? A. Release of endotoxins. B. Involves muscular compartment. C. Debridement not needed. D. Broad-spectrum antibiotics not needed. Or E. Oral antibiotics preferred.
The right choice is B. It involves the muscular compartment. Gas gangrene involves deep muscle compartments resulting in myonecrosis. The absolute cornerstone of management is immediate, wide surgical debridement or amputation, plus high-dose empirical intravenous broad-spectrum antibiotics to halt toxin synthesis. MCQ 51. Which combination of toxins and enzymes secreted by C. perfringens is responsible for cell membrane destruction and tissue spread? A. Alpha toxin. B. Beta toxin. C. Hyaluronidase. D. Alpha toxin and hyaluronidase. Or E. Hemolysin. The correct answer is D. Alpha toxin and hyaluronidase. There is a deeply destructive synergy here. The alpha toxin is a lecithinase that cleaves cell membranes, causing massive necrosis and hemolysis. Meanwhile, hyaluronidase acts as the spreading factor, degrading intracellular hyaluronic acid to accelerate rapid bacterial migration right through those tissue planes. MCQ 52. Intra-abdominal collection following open cholecystectomy is an example of what classification? A. Superficial SSI. B. Deep SSI. C. Organ space infection. D. Sepsis. Or E. Multi-organ dysfunction.
Choice C, organ space infection, is correct. The CDC classifies surgical site infections strictly by depth. Superficial incisional involves only skin and subcutaneous layers. Deep incisional involves muscular and fascial planes. Organ/space involves any manipulated anatomical cavity deeper than fascia, like a subphrenic abscess. That concludes our board review explainer. So the critical question to leave you with is this: are you proactively anticipating these infectious surgical complications based on mechanism, or are you just waiting to react when the fever spikes?